Hey guys, thanks for logging on. Sorry about that. We wanted to spend a couple extra minutes to allow some of you latecomers to log on. We have a decent amount of you guys, so thanks for coming. So here we're going to talk about anemias. At Picmonic, we like to refer to them as the anemones, and that's because we're a visual learning community. For those of you who already know us and like us, you're going to learn how to straighten out all the anemias, how to remember them from a fundamental basis. And for those of you who are new, we're going to teach you about how Picmonic works and how we're going to remember things, okay? So my name's Shehran Islam, and I'm certified. I'm a doctor. I'm a resident right now. I'm the former content director at Picmonic, and now I'm a medical education scholar. So I help come up with a lot of the info, help translate that information into cool Picmonics for our creative team here. So for those of you who don't know what Picmonic is, what we do is we help you master hard-to-learn concepts or topics by turning them into phonetic representations, things that are semantically representative of what they do. So here, Picmonic, we use picture mnemonics. We're going to use phonetics. For example, here, penicillin is the pencilvillain, amoxicillin is the armored ox, and they're going after a bacteria because they're antibiotics. This slide here is going to help you understand that we really value character consistency. So if you see herpes in one Picmonic, you're going to see it in another Picmonic too, and we always use these characters. So once you learn herpes as the harp or warfarin as the warfairy, you're going to be able to identify it, and it's going to have that quick recall that much faster when you see it again in a different drug or a different disease or different pathophysiology Picmonic. We cover quite a few subjects. We do bugs, drugs, psych, pediatrics, and that's not it. We pretty much cover biochem. Anything you're going to see that's important for step one, we cover it to some extent. I also want you to understand that we are working on further topics for step two, and Picmonic is going to be one of those products that you want to use from your first day of med school all the way to the very end because we have that much content. We have about 1,000 different topics, and we can go on and on and on, but just a couple quick examples here. Quick recall, okay? Granuloma, granuloma. You see those in Crohn's disease where you have cobblestoning shown by the cobblestone floor. Emphysema, emphys zebra. It's an obstructive disease, and that's why he's obstructing the lungs airway. So that's what Picmonic does, and for those of you, this is just repetition. You guys already know these characters. So let's get started about today's topic. So anemias. What we're going to do is we're going to review the symptoms for anemia, help you describe just the underlying mechanism of what causes anemia, how blood cell production goes, and then really how to classify them. A lot of you guys will look at that chart in first aid, or you'll look at the pocket notebook for medicine that really just tells you how to memorize things. But if you don't understand where these anemias are coming from or how they're being started, it's going to be easy to forget them. It's going to be easy to get them mixed up. So what we're here to do, and what I'm here to do specifically, is help ingrain this foundational knowledge. Okay, so what is anemia? A lot of people get very specific. Anemia is when your blood cell count is this low, when your hemoglobin is this low. Let's just think of it as something very simple. It's the lack of red blood cells. Okay, and there's a lot of different mechanisms and ways that we have a lack of red blood cells, so let's just get into it, okay? So people with anemia, and those of you who are in clinicals, or for those of you who are very astute and just know diseases that are associated with anemia, you're going to see fatigue, tachycardia, shortness of breath, right? Things that are going to help you get oxygen into your blood. Headache, because you're maybe not having enough oxygen perfusion. Difficulty concentrating, dizziness, pale skin. These are all very, very non-specific, right? But they definitely tip you off for anemia. And these are some more symptoms that are associated with specific diseases, okay? Have you guys ever heard of pica before? It's really interesting. It's when you're like so deficient in iron that you have this weird urge to eat dirt. The koilonychias, so the nail disorders where you have like clubbing or like just bowed shape of the fingernails. With neonatal jaundice, you'll see, or with neonatal anemia, you'll see jaundice, delayed growth in kids. With hemorrhagic, you'll just see bleeding, okay? So these are very, very simple, and we're going to get a little bit more complicated. So let's think about blood production in a very simple sense, okay? Think of it as like your kidneys to your bone to blood, okay? So your kidneys produce erythropoietin, and this is the main stimulus, the very beginning of blood production, okay? Your kidneys produce erythropoietin, and this stimulates the inside of your bones, so your hematopoietic stem cells, which is your bone marrow, to produce red blood cells, okay? And so here we have the kidney, we have the bone marrow, so if you see this marrow, it's shooting up, and earth red Putin for erythropoietin. So you'll never, I mean, it's just funny. He's a funny character. Okay. So your marrow contains hematopoietic stem cells, right? And this marrow produces these things called erythroblasts. Think of the word blast as like young. So these erythroblasts have DNA in them. And these erythroblasts then mature and they turn into cytes, erythrocytes. Okay? And blasts to cytes. And erythrocytes, otherwise known as red blood cells, they transport oxygen. They live about 120 days, so every 3 months you're going to have turnover. Or 4 months you're going to have turnover. And the biggest thing to remember with erythrocytes is once they mature, once they turn into red blood cells, there's nothing in them except for hemoglobin. There's no nucleic information, there's no DNA, okay? And this is important, and it's going to help us, understand what's going on here. So let's break down anemia, right? So we have underproduction and destruction. So you have a lack of red blood cells. Either you're not making them fast enough, or you're breaking down what you have, okay? Think of it in those two very general senses. Now in the underproduction, viewpoint, there's a couple ways that you can start it, right? Your kidneys, which produce the erythropoietin, your kidneys could be damaged, so you don't have EPO. Or you have bone problems. So let's say that you need your marrow to produce these erythroblasts. Let's say there's a tumor in your bones, or you have an infection and your bones aren't functioning properly. Let's say there's fibrosis, or there's not enough physical space within the bone marrow to actually create these cells. If your erythroblasts couldn't be formed correctly because you don't have the correct DNA precursors needed. And then we go into the red blood cells. Let's say that there's a problem with hemoglobin production. So there's a lot of things that can cause underproduction. And on the other end of the spectrum, you're making blood cells, but you're breaking them down. So your immune system could be attacking them. You could have pathogens like viruses, bacteria, fungi. You could have drugs. You could have mechanical destruction. So you could have an artificial heart valve that's chomping up your blood cells. And you could be hemorrhaging. You could just be losing your blood out of your body. So that definitely counts as a lack of red blood cells. Okay, so think of these two different schools, right? Underproduction and destruction. Now think of little rules that go with them, okay? So with destruction, your body is going to want to work overtime to replete what you're destroying. So your bone marrow is pumping out young red blood cells. And they're pumping up so fast that they end up being in between erythroblasts and erythrocytes. So the mature ones are erythrocytes, and blasts are very young. Your body is just pumping them up so fast that you get these things called reticulocytes. Okay, and now with underproduction, you don't have the tools. You don't have DNA. You don't have bone marrow space. You don't have erythropoietin, and because of it, your body isn't making erythroblasts or cytes. You have low reticulocytes. So this chart's pretty cool. It's just a very generalized way for you to understand underproduction versus destruction. As a general rule, you're going to see that reticulocytes are lower than 3% with underproduction. And with destruction, the reticulocytes are above 3%. So again, in underproduction, you're not making enough RBCs effectively, hence your reticulocytes are low. Can't stress this enough. With destruction, reticulocytes are being made more because your marrow is working hard because you're destroying everything, right? So look at this blood cell. trying to stack them up, but they're falling down. And then on the other side, on the destruction, he's destroying everything, okay? So use that as a way to remember. And the reason it's a baby blood cell is because it's a reticulocyte. Okay, so underproduction, use the bone marrows going down with the less than 3 reticulocyte. Meanwhile, with destruction, think of the reticulocytes being greater than 3, okay? And this giant anemone here in the center here, that is for anemia. All right. Get it? Good. Okay. So let's talk about underproduction. So the first little block here. So with underproduction, this is where we start hearing the terms macrocytic, microcytic, normocytic. But the underlying idea is we're not making blood cells well. Okay, and the macrocytic, microcytic, normocytic, all of this stuff, where does that term come from? It comes from your MCV, or your mean corpuscular volume. And what this is like I'm in the lab, and I'm looking at your blood cells, and what I'm doing is I'm just measuring the average volume of these red blood cells. So in my little field that I see under my microscope, I'm just going to measure the average size, and I come up with an MCV. They have like computers that do this now, not people. And based off of that, you can classify something as macrocytic, microcytic, or normocytic based on the size. Okay, so a macrocytic is something that has a mean corpuscular volume greater than 100. And this is something you're going to see when you get your lab sheet on the patient. You're going to see the MCV. If it's above 100, you're going to say it's macrocytic. And again, with macrocytic, we want to say, this is a general rule, that there's decreased DNA precursors. In comparison, with microcytic, and microcytic meaning smaller, the MCV is below 80, we want to say with microcytic there's decreased hemoglobin. Lastly, with normocytic, which is within the proper range that you should have, everything else. So if it's not hemoglobin related, it's not DNA related, it's something else. Okay, so let's talk about the microcytics. So microcytic means small cells, small red blood cells, okay? And they're less than 80 micrometers cubed. And pretty much you have a problem making hemoglobin. And think of hemoglobin as 2 parts, heme and globin, right? So heme is made of protoporphyrin and iron. And globin, the globin chains, they're either alpha globin or beta globin. And a lot of you guys are already like, oh yeah, alpha thalassemia, okay. We'll get to that stuff, okay? But yeah, you're starting to make these connections, good. So here we have He-Man, and he's got a snake. So we're gonna talk about what these characters mean. So why so small? So this is really cool. This is something I didn't learn in med school. I learned this in residency, okay? So normally, your cells have a specific amount of hemoglobin. And the idea is that you have this even concentration of hemoglobin within a red blood cell. Now, with a microcytic, you have problems making heme and globin. So heme and glob isn't made enough. And what happens is, in a normal-sized red blood cell, you have a decreased concentration of these guys. So what does your body do? It undergoes extra divisions to maintain that concentration. So this small guy here, these one-man hemoglobins that you see in these small red blood cells, has the same concentration as this guy. And that's essentially what your body's trying to do. And that's why these cells are small. Okay, so the problems with making heme. So one of the first things is protoporphyrin. So a lot of you guys are thinking, oh, porphyrin, porphyria. Oh yeah, that's right. So there's that pathway that leads to, you know, what's it called? Heme synthesis. And things that interrupt that heme synthesis pathway, there's sideroblastic anemia and lead poisoning. So we have the lead bullet and we have the cinder block on the anemone. And remember those. Okay. And then we have protoporphyrin problems, and you also have iron problems with heme. Okay? So heme, protoporphyrin, and iron. Now there's a lot of things that cause iron, you know, deficiency or problems with having iron in your body. The first thing is iron deficiency anemia. So this happens to a lot of people. You can have chronic blood loss. This is going to be your patient that notices blood in their stool regularly over the course of 6 months. You're going to have people who have pregnancy, people with parasites. Imagine that you have a parasite in your body and it's taking away a lot of your nutrients, like iron. Just of note, the pregnancy and parasites should be separated. And then also you can have decreased absorption of iron. So if you have some kind of gastric surgery or some kind of intestinal disorder, you can have decreased absorption. And then a lot of people have anemia of chronic disease. If you're sick, if you chronically are ill or have inflammatory disorders, or there's a lot of things that cause anemia of chronic disease. Okay, so you have this anemia with the Crohn and of broken iron. So iron deficiency anemia is caused by anemia of chronic disease. It's one of the causes. Okay, so we talked about the heme part, iron and protoporphyrin, and then there's globin. So what causes globin problems? So thalassemias, of course. So the talisman, and there's a little anemone on there, so you won't forget it. And just so you know, just all the alpha and beta thalassemias, we have a lot of Picmonics on these, just describing them in more detail. But just for you to remember, thalassemias are within microcytic anemias. Okay, so macrocytic. So we talked about, let's just go back to the big tree because I don't want you guys to get lost, okay? So underproduction, and then underproduction, we classify them by size. So microcytic, we describe microcytic. And now we're moving to macrocytic. These are really big cells. You're still not producing red blood cells effectively, though. So why are they so big? And this is also really cool. I didn't know this and didn't learn this in med school. So these cells are huge. They're bigger than 100 micrometers. And so what you're going to see is these cells are really big. Now, why do they get big? So this is really interesting, okay? So typically, you have this cell cycle, and you have checkpoints. So do you remember G1, S, G2, M? You thought you were never going to see them again. Well, they're back, okay? And what happens is in G2, your body essentially checks these red blood cells, and it checks to see if DNA is copied correctly. Now, remember, in macrocytic anemias, you have problems with DNA synthesis. Microcytic, what do you have problems with? Hemoglobin. Macrocytic, synthesis of DNA. Okay, so your DNA isn't quite up to par in G2. So what your body says is, okay, I'll go through that cycle one more time. So the cell grows and grows and grows, waiting for this DNA to catch up. And what ends up happening is that the DNA never catches up because you have a synthesis problem. So these cells just get really, really big. Okay, and it's not just red blood cells. Sometimes you see things called polysegmented neutrophils, and that'll help tip off that sometimes you have a macrocytic anemia. And so the polysegmented neutrophil, you'll see here huge different segments of the maturing nuclei in there. Another thing to notice is that, or to realize, is that RNA production proceeds normally. And so that's why like the cytoplasm and the cell components grow big, but the actual nucleic acid doesn't. Okay, you have these really big cells. Okay, now within macrocytic, if you're looking at like a chart from the textbook, you're going to see, well, okay, I understand macrocytic now. There's a lot of causes, but what's the difference between megaloblastic and non-megaloblastic? So we're going to talk about that. So let's break down the word. Megaloblastic anemia. Mega, big. Blast means immature. And you're going to see these on peripheral smear too. So you look into your microscope and you're going to see these big immature cells on peripheral smear. Okay, so why are they big and immature? Well, you have problems with DNA synthesis, like we said before. Now there's a pathway that it takes like dihydrofolate and turns it into tetrahydrofolate. And for a lot of you guys who are getting ready for step 2 soon or this year, you'll know that there's like certain drugs that inhibit that pathway or certain inherited disorders that inhibit that pathway. And what it leads to is decreased DNA synthesis. So the causes of megaloblastic anemia, you have decreased folate, right, which is also known as vitamin B9. And then this goes into a conversion pathway to create THF, or tetrahydrofolate. And this is really important for DNA synthesis. A lot of times people can have decreased B12. If you have decreased B12, you're going to have a megaloblastic macrocytic anemia, as well as orotic aciduria, which helps, or orotic acid is also involved in the pathway to create DNA. So people with this inherited disorder called orotic aciduria, they can have a megaloblastic macrocytic anemia. So the foliage for folate, the B12, so the B's in the 12 egg carton, they're all dead, and then the orotic lemons for orotic aciduria. That's funny. Okay, so let's talk about B12. So with B12, it's necessary for converting homocysteine to methionine. If you can't do it, you have decreased DNA synthesis. Okay. Another one is you could have B12 that's absorbed in the stomach and ileum. So people who have some kind of bypass surgery, some kind of resection due to a cancer or Crohn's disease, people who have tapeworms, they can have decreased absorption of B12, and they could have a megaloblastic macrocytic anemia. Another group of people have this thing called pernicious anemia, where they have decreased or absent intrinsic factor. And intrinsic factor is important for transporting B12 and helping absorption. So if you don't have intrinsic factor, you have a disease called pernicious anemia, which causes a decrease in B12. Okay, let's talk about folate. So folate is necessary for DNA production, right? And it helps form the purines, which are pure as gold, adenine, and guanine, PAG. And this is found in leafy greens, and it's easily repleted, meaning like you don't have a huge store, but if you eat leafy greens like spinach, you'll build it up in your liver. And it's absorbed in the stomach and duodenum, and people who are malnourished, people who are alcoholics, so they go on a 3-day bender drinking alcohol, they're going to deplete their folate stores. Kids who don't eat enough, pregnant women who don't eat enough. And that's why folate's actually included in a lot of different foods as like a fortified nutrient. There's also some drugs, and these drugs you've definitely heard of before: methotrexate, Bactrim, AZT, and cyclophosphamide. All of these drugs inhibit not exactly this pathway, but the pathway that takes dihydrofolate reductase and uses that enzyme to create tetrahydrofolate. So in the end, we have another inherited disease called orotic aciduria. And this is a defect in UMP synthase. And this enzyme UMP synthase helps convert orotic acid into UMP, which then helps DNA synthesis. Without it, you have DNA synthesis problems, okay? So if I ask you, macrocytic anemia, what's the fault? What's the big picture problem? DNA synthesis. Okay. So we talked about what causes a megaloblastic, so like immature, big, right? And here we also have non-megaloblastic anemias, and they're still macrocytic. They have big cells, but they have mature. They have mature DNA. So you have macrocytosis without DNA replication problems. And what you end up having is a disproportion in the creation of the surface area of the cell in comparison to the DNA in the center. Okay, so you have, it's what's called a relative membrane excess. Imagine that like you're a kid, you're growing at a normal pace, but your clothes are growing really, really, really fast. You end up having like a big body or a big outline of your clothing, and that's kind of the same way that non-megaloblastic anemias work. Okay, so what would cause it? So liver disease does, alcoholism does, reticulocytosis. So if you're getting transfused or you have blood products given into you, what ends up happening is you have this stimuli that tells like your cell membrane to grow, but your nucleic acid it's being produced, but not as quickly as the membrane is. Okay. All right. So those are the macrocytics. So going through macrocytic, we have the megaloblastic and non-megaloblastic. Okay. Now normocytic, if you go to the underproduction anemias, is the third one. So we went microcytic, macrocytic, which have the two branches, and now normocytic. Okay. Normocytic has a couple branches too. So there's non-hemolytic, which means the cells aren't being destroyed. They're just being underproduced, okay? And we talked about anemia of chronic disease. Anemia of chronic disease can also be a normocytic anemia. And if you have cancer, if you have some kind of non-infectious inflammatory disease, your body produces a lot of cytokines and interleukins and stuff. And so one of them is interleukin 6. And what interleukin 6 does is it produces this thing called hepcidin, which pretty much causes your body to be very stingy, and you don't release iron. So these inflammatory cytokines like interleukin 6, which we just described, I want to go back because I want you to appreciate the none with the red blood cell for non-hemolytic. And we have this normal anemone for normocytic anemia. And what you want to understand is that these inflammatory cytokines suppress proliferation of precursors. So they can suppress iron from being released. They could suppress erythroid precursors in the bone and marrow. They can inhibit your body from releasing EPO from the kidney. And they could essentially cause your red blood cells to live for a lot less time due to inflammation and that idea. Okay, so one of the most common types of normocytic is aplastic anemia. So there's a lot of different causes for it, and because of that, it's really hard to classify, like mentally, like what causes aplastic anemia, because there's so many causes. The first thing you want to realize is that it's actually not just red blood cells, but it's white blood cells and platelets too. And when you think about like what causes it, it's just a toss-up. It's like parvovirus B19 is a huge board question that you see sometimes. Make that association, parvovirus B19, and imagine this plastic anemone. But there's like so many other causes. Certain drugs cause it, chemicals, radiation, specific autoimmune diseases, heredity, and then Fanconi diamond blackfin syndrome. But I think the big takeaways are remember certain drugs and remember parvovirus B19. So another one that causes an underproduction but normal sized cells is chronic kidney disease. So in the kidney, it does a good job of filtering if you're healthy. And if you're not healthy, you build up uremia, or uremic metabolites. If you ever get a lab value when you have a patient with chronic kidney disease, they're going to have something called a high BUN or BUN, blood urea nitrate, and so that just tells you that you have high uremic metabolites. And these metabolites are like, so uremia is toxic to red blood cells. It ends up just killing them and lysing them. Okay. Also, if your kidneys are diseased and hurting, you're not going to produce EPO as efficiently as anyone else could. And then this is just a note for you. So we talked about iron deficiency being a different type of anemia. Early iron deficiency is actually sometimes a normocytic anemia, and people can switch. So you'll see them if they're early, they may be normocytic. And then later they'll be microcytic. So the crone here on a kidney is chronic kidney disease, and then we have the early sun with the iron for early iron deficiency. Okay. All right, so I just want to do a quick summary. We talked about underproduction. So in underproduction, we have 3 different sizes. We have micro, macro, normal. And the general rules, okay, with micro, you're not making hemoglobin, heme or globin. With macro, you're not making DNA. In normocytics, everything else, like your kidney, like drugs, like, I forgot, there's so many. Okay, so now let's talk about the destruction anemias. So hemolytic means like blood break. So you're lysing it, you're hemolyzing the stuff. And there's 2 ways to classify these, okay? So there's the intrinsic way of hemolyzing cells, and there's the extrinsic, okay? So the intrinsic and the extrinsic. And just think of it like this. So there's something from within the cell trying to break out, or there's something trying to break into the cell. And if you classify it this way, it's really easy to remember the causes. Okay, so intrinsic. Have you guys ever heard of a disease called PNH, or paroxysmal nocturnal hemoglobinuria? Okay, so this is a really interesting disease where you'll have a patient who, like, they wake up in the morning and their pee is like really dark, but then it gets lighter during the day. And it's because at nighttime, they have complement attack glycolipids on the proteins of the RBC membrane. So when you sleep, like you kind of get a little apneic, you stop breathing as much, you get a little bit acidotic just because your body's in such a calm state. And people with this disease, their body like freaks out and complement starts breaking apart red blood cells. So in the morning when they wake up and they're breathing fine, their blood cells are protected, but all the things that got destroyed in the night, they pee it out. So that's why it's hemoglobinuria, they pee it out. Okay, so that's why you have the pair ox with hemoglobin, and he's wearing, or He-Man globe, and he's wearing night vision goggles. So you startled him in the night and caused him to pee. Pretty cool visual. Okay, another one is hemoglobin C. So He-Man globe, and he's on the C cat. And that's because hemoglobin C is another intrinsic destruction anemia, where you just have, an inherited defect where you substitute glutamic acid on a beta globin chain. More specifically, it's substituted for lysine at the 6th position. But just remember that you have an erroneous beta globin chain for hemoglobin C. And then the other intrinsic ones, you have pyruvate kinase deficiency. So pyruvate kinase is really important for the ATP pathway and making energy, and so glycolysis doesn't occur. And without energy, your cells don't really mature and grow as they should, and they're weak, and they shrink, and they lyse, and they break. Okay, we talked about intrinsic. Next we have extrinsic. Okay, so this is things causing your cell to break or bust. So IMHA, so immune-mediated hemolytic anemia. This is going to be things like autoimmune diseases, things like lupus. Your body is destroying red blood cells from the outside. Okay, and then there's microangiopathic, or MAHA. And this is interesting because you have microangiopathic, so micro, small, vessel, something's wrong. Something's wrong with your small vessels. Oh, I get it. Okay, so things like HUS, mechanical valves, TTP. Essentially, imagine that you have a blood vessel, right? So my hands, this is a blood vessel, there's blood going through. And for some reason, there's stuff causing these, my angio area, so my blood vessel, to cause destruction. So a great example is if someone had a valve transplant or a valve replacement when they were when their heart wasn't doing well. Those mechanical valves can crush and break cells. People with DIC have what's it called, coagulation pathway defects, but it's all within blood vessels. And so what you're going to see, I'm sure you've heard these terms before, schistocytes or helmet cells. So schistocytes are they're just the half blood cells that are broken apart. Helmet cells, they're these warped, broken blood cells. So these are things that you're going to see with destruction. Think of helmet, schistocyte, destruction. Malaria. So malaria does it too. Blood transfusions. So if you get a blood transfusion and you have some kind of incompatibility, you build up tolerance to certain HLA subtypes, and you get a blood transfusion, and all of a sudden you start reacting poorly. That's an extrinsic destruction anemia. Have you guys ever heard of Rh incompatibility? So if you're a mother, and I'm a mother, I'm Rh negative, I marry a man who's Rh positive, we have a beautiful kid together, and our kid is born Rh positive because that's dominant. So the mother gives birth to this kid in the natural way, and she builds up these antibodies to Rh. She's like, if I see Rh again, I'm going to attack it. Well, guess what? Her and her husband have another kid. He's also Rh positive, and this time she's equipped and she attacks him. So Rh incompatibilities cause another destruction anemia. And that's essentially it. So if you guys go to Picmonic.com, we have this chart, and it's a mirror of something you'll see in a popular textbook, but a more graphic version. And we can kind of go through it, right? So this is actually just all the different, because the destruction anemias are pretty easy. You know that either they're being destroyed from the outside or something inside is causing a problem. With these, we can break them down into microcytic, normocytic, and macrocytic. And then within normocytic, you can see some of the destruction anemias here. But just use this as a quick reference to help you organize characters. We're putting in audio tracks so that you're able to really understand the source. You can trace microcytic all the way down, and then you're going to be able to say, like, okay, this late moon, so I don't remember what the story is. I think the audio is still in production, but these are completely free. You can print them out, and you can memorize these pictures, or remember the cool interactions. And that's essentially how you're going to get these anemias straight, okay? You guys can sign up for Picmonic for free. We have a free trial. For those of you who are already signed up, we have about a dozen other Picmonics that describe anemia. Just going quickly, like in the top left, we have hemolytic uremic syndrome. Below that, we have hereditary spherocytosis, so the hair red with a spherocyte. So these are all really funny. I'm just kind of cracking up just looking through some of these. So if you guys have any questions about what's going on, you can send any inquiries to feedback@picmonic.com. And with that said, I will take questions now. So if anyone has any questions, feel free to ask me. And I'll just kind of go on and on until you guys do ask questions. So something that people will typically get quizzed on with anemias is they're never going to ask you, for those of you who are getting prepped for boards, they're never going to ask you, like, a patient has a MCV of 100 and they have, been drinking alcohol. What is missing? Like, that's a little bit too easy. What they may do is they may say, like, the patient was found down and he was drunk and he reports that he hasn't eaten in 3 days. His MCV happens to be 100. What do you expect to find? So the better you know these and the better you know the causes, you're gonna be able to answer these questions better. Yeah, so hey Lena, you just asked the question, would it be possible to review some of the other lab values? So initially when we made this talk, we wanted to go over like ferritin, transferrin, all of those things so that you could really remember them better. And I think what we're going to end up doing is have another webinar to describe them, because I don't want to, we're about 40 minutes in, and we're going to run out of time. And we have a ton of general rules. We have a couple Picmonics that involve just those lab values. And I don't want to give you guys a shortened version or something that's going to confuse you. So we're probably going to put it on the docket for another talk. But what she's referring to, if for those of you who don't know, there's a lot of like easy charts. Like if you're on rounds or if you're like just studying anemias for step 1, it'll be like, oh yeah, ferritin's up, transferrin's down, transferrin percentage is this, and you memorize these general rules to help you figure out what it is. Yeah, I just think for time's sake, I don't want to get completely into it, but that's a really, really good question. I'm glad you asked it, because we're probably going to do that. Anything else? Okay, let's see here. So the rules that I'm talking about, a couple textbooks have them. So like Pocket Medicine by Mass General Hospital does. They actually describe it in first aid too. They just don't do a really good job differentiating between transferrin and transferrin percentage. So a lot of people get confused. And because of it, I want to just like set the world straight. This is how you remember it. Okay, and I'm going to turn off the webcam, but you guys can keep asking questions, and we will we'll make sure to answer them for the next 10 or 15 minutes. So Stephen asked a question, how do I tell the difference in a question stem? And I want you guys to use like the tree type processing. So like think of it in terms of size, and that'll really help you break it down, right? So you'll have for example, they'll say, okay, a man is from the Middle East, he just moved to the US, he doesn't have a primary care physician, he states that he's been sick as a youngster before, his English is poor, however, we see that in his lab values, his MCV is like below 80, so it's a microcytic, and immediately, once you know it's microcytic, you want to think, okay, is it a problem of heme or globin? So then you ask him, if he has a good diet, if there's, any iron deficiency, anything like that, any bleeding. And in a question stem, they'll make sure to say that. They'll be like, the patient states that he's had blood streak stools for a year, or he has a malignancy, all of those things, or he's on treatment for a parasite. So all of those things, you're like, oh man, that's a problem with heme or iron. But then if you realize, okay, he's Mediterranean, he's had transfusions in the past, it's been going on since he's a kid, you think thalassemia. But the biggest thing, the easiest way to help differentiate everything is to start by doing the size of the MCV. Okay, so someone asked a question about DIC. So DIC causes a microangiopathic anemia. I kind of skipped over it, but we can talk about it in more detail. Okay, so DIC is a great example of like a mixed coagulation issue. So with DIC, you have like some kind of external stimulus, like you're given heparin and you react to it, or you have some kind of infection that sets off a switch in your body. And what ends up happening is you end up actually coagulating. So you activate a coagulation pathway, and you have these ultra large like platelets that are activated. At the same time, you have all this thrombosis, but at the same time, because you have this thrombosis, all the blood cells that normally go through vessels like they would any other day, they have these clots that they have to deal with. So imagine that you're this blood cell and you're traveling along like, the renal artery, and all of a sudden there's all these clots that quickly formed because of maybe someone gave you heparin and you had heparin-induced thrombocytopenia, or because you had an allergic reaction to a drug, or because you have a bacteria. So you have this rapid clotting, and then these clots end up like breaking down your blood cells as they shoot through. So it's actually an interesting disorder. It's a mixed coagulation defect. Someone asked a question, so what's your name? Where's Kendall? So my name is Shehran Islam. I'm a first-year resident in Washington, D.C., and I've been working with Picmonic for a few years, and Kendall, who is another one of our webinar hosts, he's actually in the office, and he's doing some other things, but he and I sometimes switch. So Kendall does a lot of nursing and basic sciences, and this is a more medical, like medicine geared approach towards anemias. All right, so if you guys have questions later on, feel free to email us. It looks like we've got a lot of shy people in here. So it seems like, it looks like we've got a few shy people in here, so we're going to just wrap up. Again, you can reach us at feedback@picmonic.com, and we'll see you next time. Thanks for tuning in, guys.